Welcome, everybody. I'm Neil Winger from the Ethics Center, and have the great privilege to welcome you to a special presentation that we're able to bring because this is done in concert with the Dean's Office. And we have three people who will speak today, but one who will actually give an introductory talk. And then the purpose of this is actually to have as much of a discussion and conversation about this issue as we can. This is something we don't often get to talk about out loud, and this is a time to have that opportunity. Kimani Paul-Emile is going to give the introductory talk. She's an associate professor of law at Fordham and associate director of the initiatives in their law and ethics program. She's written very provocative things, only one of which I think she's going to talk about today, and is actually having an effect on the field and how we think about how we interact with one another and I would say race relations. She's funded through the Greenwall Foundation, through RWJ, and other places, and her talk will be on dealing with racist patients. Then we'll have Dr. Alicia Fernandez, who's a professor from UCSF, who has done quite a bit of work in this area, and Dr. Robert Brooke, who is an emeritus professor here at UCLA and was the head of Rand Health for, I think, about 20 years. And they will join her on the panel. I believe Dr. Duru will ask them some questions, and then we're going to try to foster a conversation from everybody. Without no further ado, Dr. Paul-Emile.
Okay, thank you for that introduction, and good afternoon. So Alicia and I are very pleased to be here today to talk about an important issue that's been getting a lot of attention lately, and that's what to do when the patient is racist, and what are the legal, clinical, and ethical implications for patients, providers, and healthcare institutions. So I'm going to start with a case study. A 57-year-old man enters the emergency department late one night with shortness of breath and a fever. A nurse does an initial workup, and she thinks his condition could be serious, so she goes to get Dr. Jones, the on-call physician, to evaluate the patient. When Dr. Jones enters the room, the patient says, "Oh, I'm glad you're finally here. My television hasn't been working. Can you please just fix it?" Dr. Jones explains that she's his physician and she's here to evaluate him, and the patient gets agitated and turns to the nurse and says, "Get this woman out of my room. I want a real doctor." Now, you can fill in the blank here with respect to the rejected physician. It can be a Latino physician, an Asian physician, a Muslim physician. Any of these categories apply. And scenarios such as this are more common than one would think and occur at hospitals all over the country. In fact, I call it one of medicine's open secrets, because you'd be hard-pressed to find a physician, but particularly a physician of color, who hasn't had this experience or who doesn't know someone who has. And this issue has gotten a lot of attention, a lot of media attention lately due to the changing sort of social and political climate as evidenced by recent events in Charlottesville, Virginia, and elsewhere. And what makes these physician-patient encounters so challenging is that they raise many thorny legal, ethical, and clinical questions for all the parties involved. So, for example, although physicians have an obligation to treat all patients, even those they find distasteful, these encounters can be painful and degrading experiences for the rejected healthcare workers, so not just physicians, but all healthcare workers. And these scenarios are particularly difficult when the patient is competent, but not stable enough to be sent elsewhere. So before we get too deeply into it, I'm going to take a moment and go through all the primary groups whose interests are affected when these cases arise. So what are the three groups who you think whose interests are most directly implicated when patients reject healthcare providers? Patients. Someone said patients, exactly. Who else? Healthcare workers. So nurses, right? Doctors, residents. So healthcare workers. We have patients and healthcare workers. And then what's the last? I'll give you a clue. institutional, hospital. So someone said it before I did. Perfect. So we have patients, healthcare providers, and healthcare institutions. So let's take a moment and go through their rights and obligations. And we'll start with patients. Competent patients have a right to receive stabilizing treatment. This is in keeping with EMTALA, the Emergency Medical Treatment Act and Active Labor Act. It requires hospitals to screen and stabilize if necessary, or to arrange for a transfer of competent patients with patient's consent, transfer the patient to a facility able to provide appropriate care. So that's EMTALA. Patients also have a right to refuse medical treatment, which includes the right to refuse wanted care from an unwanted physician. This right to refuse is a well-respected legal and ethical principle based in informed consent and legal rules that protect patients from battery, which is unwanted touching. Many hospitals also have patient Bill of Rights documents, which sometimes have explicit language about a patient's right to refuse treatment from unwanted providers. So I was recently up at Brigham and Women's Hospital in Boston, and here's theirs. And you'll notice at the very bottom, it says you have a right to refuse to be observed, examined, or treated by students or any other staff without jeopardizing your access to care. Okay. So let's now turn to healthcare providers. Healthcare providers have a duty to treat, but they also have employment rights that have to be respected. They have the right to a workplace free from certain types of discrimination, particularly discrimination on the basis of sex, race, ethnicity, religion. These are considered legally protected classifications. Okay, institutional rights and responsibilities. Healthcare institutions have to abide by EMTALA. Again, this is the patient anti-dumping statute. Requires hospitals to screen and stabilize patients if necessary. And institutions also have to protect their employees' rights. So, for example, if a healthcare institution continually forces its clinicians or nurses to treat or refrain from treating a patient who's rejected them on the basis of race or ethnicity, then the healthcare institution could be liable for creating a hostile work environment. Okay? All right. So to recap, these are the three primary groups, and of course there are other groups whose interests are, related in different ways, but we're going to focus on patients, providers, and healthcare institutions. Now, at this point you're probably thinking, okay, this is straightforward, I get it, but it can get murkier the deeper you go. So for example, should the race or ethnicity of the patient matter when these cases arise? So should we distinguish among different types of patients making these requests? And on the healthcare provider side, should different types of healthcare professionals have different rights and obligations? So does and should the law differentiate between doctors or nurses or residents or other healthcare providers? And on the healthcare institution front, are they damned if they do, damned if they don't? So for example, if they accommodate a patient's demands for a doctor of a different race or ethnicity, are they discriminating against the assigned physician and opening themselves up to legal liability? But if they don't accommodate the patient's demands, will they be liable for violating laws against battery by forcing the patient to be treated by an unwanted doctor without consent? But on the other hand, if they don't screen and stabilize the patient, then they'll be liable for violating EMTALA. So it's complicated. What do you do? There haven't been any clear guidelines on how to effectively balance all of these concerns. So my co-authors and I, including Alicia Fernandez, we devised guidelines in an article we published in the New England Journal of Medicine. And prior to that, I wrote a lengthier piece, coincidentally, in the UCLA Law Review, where I laid out the legal, how we should think about this from a legal and ethical perspective. And when I have to say, when I first heard about these scenarios that patients sometimes reject doctors based on their race or ethnicity, I was shocked. My first instinct was this type of behavior shouldn't happen, and if it does, these patients most certainly should not be accommodated. So I began researching the issue. And as you know, I'm a law professor, and I research and write on issues that emerge at the intersection of anti-discrimination law, bioethics, and health law. And so I initially focused my research on identifying the laws that could be brought to bear on this phenomenon. And this led me to the Civil Rights Act of 1964. It bars discrimination on the basis of sex, race, ethnicity, religion, and specifically Title VII, which is the employment discrimination provision. Among other things, it says that employers can't cater to the discriminatory preferences of their clientele. So, an example might be you go into a restaurant and you say you only want to be served by black waiters, or you don't want any Latino waiters. If the proprietor accommodates that request, then they're liable for violating Title VII of the Civil Rights Act. So this sounds a lot like our hospital scenario. And I assumed I'd find some case law here. But as it turned out, there wasn't any. There hadn't been any reported cases of physicians suing their healthcare institutions for violations of Title VII. And even though we know these types of physician-patient encounters often occur, but there were a lot of cases brought by another group of healthcare providers suing hospitals for being rejected by patients. Can you think of what group of healthcare providers I'm thinking of? A little louder? Nurses, exactly. Nurses and nursing assistants. So there are multiple reasons for why, but I think the primary reasons are that nurses tend to be employees at the institutions, the healthcare institutions where they work, while doctors less so, but are still largely often independent contractors. So if a nurse is reassigned based on a patient's race or ethnicity-based rejection, reassigned so the institution makes a decision to move the nurse, then his or her rights are violated. Title VII is violated. But because physicians tend to be independent contractors, hospitals can't have too much say over the manner and means through which they do their work. So they tend to decide amongst themselves whether to accommodate based on individual circumstances. And also physicians tend to have more autonomy to switch out patients. So they're not being forced to accommodate. They're making the decision themselves, and thus they're not suing. So in broad strokes, that's the legal landscape for healthcare providers and institutions. But it doesn't answer the threshold normative question of whether they should accommodate. So to get at that, let's look at patients. Now, the case study I opened with is what I think most people envision when they think of patients rejecting doctors or healthcare professionals based on race or ethnicity. But these cases can look quite different. So this is case study 2. We have an older Korean man who goes to the hospital with symptoms that suggest congestive heart failure. He's provided treatment that offers a very good chance of success, and he'd likely make a full recovery. And all seems to be going very well until one day he says he only wants to be treated by physicians in suits. The staff is puzzled by this request. And it's ultimately denied. And the patient then becomes increasingly withdrawn and eventually refuses treatment altogether. The hospital performs a competency test. He's found to be competent. So they respect his wishes and stop treatment. Now, this would have been the end of it had someone not noticed that he'd filled out a form requesting full resuscitation should he go into cardiopulmonary arrest. When confronted with the seeming contradiction and after some prodding, the patient said he asked whether they'd noticed that most of his treating physicians had been Japanese or of Japanese descent. The patient was Korean and elderly and remembered Imperial Japan. And he said he didn't feel like these doctors had his best interests in mind. He didn't trust them. And the reason he wanted to be treated by physicians in suits was that he noticed that a larger percentage of the non-Japanese American physicians wore suits because they also taught in the medical school. So this was sort of a more palatable or more PC way for him to ask for what he wanted. Case study 3. Here we have an African American woman. She presents with symptoms that suggest renal failure. She's fairly uncommunicative with her assigned physicians. She's giving very reluctant yes and no answers to their questions as they try to take her history. And at some point during the process, she notices an African American doctor treating another patient, and she points and says, "I want to be treated by him." Why might this patient be discriminating? I'm sorry? Issues of trust. Exactly. Maybe she's had a positive prior experience with an African American doctor. Maybe she'd had a prior negative experience with a non-African American doctor. Or maybe it's simple prejudice. At this point, we don't know. Okay, we're going to return to all these case studies. Let's turn to our last case study, 4. So the patient is Latina. She arrives in the ER after 2 weeks of rhinorrhea, sinus pain, and other symptoms suggestive of viral sinusitis. And as she's getting her history taken, she declares that she doesn't want the assigned Latino doctor. She wants an American doctor, which turns out to mean Anglo-American doctor. And when asked why she's making this request, she explains that she came to the U.S. because she believes things are better here, better treatments, better doctors, better services, and she associates American doctors with white doctors. Now, let me ask you a question. How is the patient's request in case study 3 different from the others? Did anybody catch it? Exactly. She's asking for concordance, right? We see this with women who want a female OBGYN or Muslim patients who might want a culturally or religiously concordant physician. So in this way, it's a little bit different, but it's still discrimination. So let's go back to case study 2 for a second. Physicians may see a similar version of this among veterans who don't want to be treated by a doctor who reminds them of a former enemy combatant. Perhaps it's bias, but maybe it's PTSD. So we can argue that discrimination is bad, and it often is, but the idea of discrimination becomes much more complex in the clinical medical context, particularly in emergency situations, or situations where you can't just tell the patient to take the doctor they've been assigned or the healthcare professional they've been assigned, or just leave. Okay. Sometimes the patient's behavior very clearly seems to be based in animus or bigotry, but other times it looks different. Now, we've talked about, I think someone just mentioned trust, and that's often animating some patients' reassignment demands. We know that trust is an important part of the physician-patient relationship, and trust is particularly important for individuals from marginalized or underrepresented communities. And this feeling of mistrust isn't just random paranoia. I mean, members of minority groups actually often have very good reason not to trust the healthcare system. Studies show that that overwhelming evidence shows that racial and ethnic minorities still tend to receive poorer quality healthcare when compared to whites, even when factors such as health insurance status are controlled. And some of this, of course, is due to structural factors. But research also shows that, sadly, there's still a lot of racial bias in medical practice. And minority patients disproportionately receive substandard healthcare due to physician prejudice. Now, studies show that the overwhelming majority of healthcare providers hold non-racist views, but studies also show that many providers also harbor implicit biases, which are thoughts and feelings that are outside of the conscious awareness, but that are difficult to control and to acknowledge. Studies also show that implicit biases against ethnic and racial minority patients, particularly Black patients, negatively affects the quality of care. It affects clinical relationships, clinical decision-making, and health outcomes. And this contributes to the widespread health disparities that I'm sure you're all aware of. However, data shows that for some patients, particularly patients of color, physician-patient race concordance can counter the effects of implicit bias, discrimination, and stereotyping by physicians, and in fact tends to promote more participatory decision-making, greater patient trust, more productive communication, and greater patient satisfaction. And all of these factors go to the core of the physician-patient relationship. Now, this doesn't mean that we need to default to race or ethnicity concordant relationships. Instead, all of this is to say that our first instinct when we hear about patients rejecting doctors based on, or nurses or residents based on their race or ethnicity, our first instinct may be to simply deny these requests. But in order to provide appropriate care to all patients, it may be necessary to distinguish between garden variety racism on the one hand and patients seeking a physician who they feel will understand their experiences, who will show them respect, and whom they can trust. So the question then becomes, how do we make this determination? How do we distinguish between these different types of reassignment requests? And then how should we respond? To get at this, my co-authors and I in the New England Journal of Medicine piece created a template of guidelines, 5 ethical guidelines that should be followed. Now, in the interest of time, I'm not going to be able to I would normally go through all of them, but because we have a panel discussion coming up next, I think we'll be able to talk about it in sort of a more granular, detailed way. But I'm just going to hit a couple of some of the factors. So very briefly, in every case, the patient's medical condition should drive clinical decision-making. And you should also assess whether the patient has decision-making capacity, because reassignment requests that appear to be based on bigotry could be due to delirium, psychosis, or dementia. So for example, in our first case study, we might want to see if the patient is cognitively impaired. Another step in this process is to determine the reason for the reassignment request, because often the rationale behind the request can be clinically and ethically significant. So for example, it may be ethically appropriate to accommodate a patient who's seeking cultural or language concordance. But as we've discussed, it's not always so clear-cut. So in our first case study, maybe it's bigotry. Second, could be that it's PTSD. The third, it's unclear. Is the patient seeking some sort of race concordance? And in the fourth, is this a misunderstanding about the physician's qualifications? Now, to get at the rationale behind the request, you should ask open-ended questions. You should ask the patient to tell you more so you can better understand his or her concerns, all the while acknowledging that these types of conversations are difficult for the patient. I mean, they know very well that you're the colleague of the doctor they just said that they don't want. And you can stress that the more open they are with you, the better able you'll be to provide the best care. Now, this can be very effective if the patient's demand is driven by anxieties or fears, but it's going to be less successful if you're dealing with animus or bigotry. So this brings us to the next factor, which is the options for the patient, options for responding to the request. And again, I'm not going to go into a lot of detail on that, but I will touch on one option, which is accommodation. For the patient in case study 2, the older Korean gentleman, this is in fact what his healthcare team decided to do. They decided to accommodate his request. He accepted treatment, he made a full recovery, and he went home. Right? But accommodation clearly isn't a perfect solution. And it obviously isn't a fully satisfactory answer to the problem of race-based health disparities and physician bias. And none of this is to suggest that we shouldn't be concerned about bigotry or animus on the part of some patients, or cases where the patient isn't just requesting concordance, but is actively, explicitly rejecting a provider based on his or her ethnic or racial background. Because this tends to disproportionately and negatively affect physicians and healthcare providers of color. And each time it happens, it's like another slice of the knife. And for some, the cumulative effect can be significant. As you can imagine, again, these are very painful and demeaning experiences for the healthcare providers involved. And they can exact a heavy emotional and psychological toll, and all of this contributes to burnout. I'm sure you may be aware of the recent case in a resident went in to meet with her patient. She introduced herself to the little girl, and she got down on one knee to give the girl a high five. And just as she was about to do it, the father turned to her and said, "Don't you touch my child. I don't want any black people treating my child. I want a white doctor." Now, as you can imagine, even if the resident decides that she no longer wants to work with this family, the episode isn't over for her. The emotional and psychological weight of the encounter will linger. Today, we're in a patient-centered culture of care, which of course is important, but we can't forget first-line providers, which are often nurses, trainees, residents. There has to be a comprehensive, formalized process in place to deal with these cases when they occur. And this is particularly important when the cases involve residents or trainees. I don't know if there are many in the audience today, but there's a recent study came out in 2016 that found that 19% of trainees experienced discriminatory verbal abuse, 93% of over 400 first-year residents have experienced disruptive behavior, including racial bias, 15% of these residents had personally experienced or witnessed mistreatment, and among these, 50% didn't know how to respond to these encounters, while 25% believed that nothing would be done if they had alerted hospital management. So this tells us something. This tells us that there doesn't seem to be enough institutional support for many healthcare providers. So institutions have to commit to being there when these occur. The healthcare staff have to know that somebody has their back. So we can think of how to deal with this in a way of coming up with best practices. So first, when an instance like this occurs, if a supervisor is present, they might want to ask the healthcare professional just take a moment and see if we're dealing with residents, for example, you might want to take a moment and see if the resident wants to handle the situation. But if the trainee or resident or someone who's new to health practice is thrown off guard, then the supervisor should immediately come in and model appropriate behavior, making clear that racist and hateful speech won't be tolerated. And if she's able, and this isn't always possible, she might want to take a moment and talk to the less experienced person, the trainee, the resident, the person in training, and ask how they want the situation to be treated, rather than just automatically making a decision about switching out the person or forcing them to continue working with that patient. After this happens, but whatever ultimate decision they make, the supervisor has to model appropriate behavior. Now, after the incident, it's important to follow up and debrief by giving the affected staff an opportunity to talk about the incident, preferably sitting down one-on-one with a point person who's trusted and has debriefing and facilitation skills, because this is about taking people's difficult experiences seriously and giving the person the chance to vent. You certainly don't want to minimize the encounter. You want to make sure that the person is heard. In addition to debriefing with the rejected healthcare provider, the institution should also address the fact that these encounters can have a corrosive effect for those who witness them, but may not know what to do or how to respond. So you may want to have a whole team meeting. The team can discuss how many people on the team have had these experiences, how they addressed them, what worked, what didn't work. And this is important because prevention is impossible, right? Members of the team are probably going to have this experience at some point in their careers, and if they don't experience it directly, they're likely going to see somebody else going through it. And by these encounters, I don't just mean rejections based on race or ethnicity. I mean rejections based on disability status, based on religion, based on sexual orientation, based on age, for that matter. Age is actually the most common basis for a reassignment request. You don't look old enough to be my doctor or my nurse. I want a more seasoned physician. So the team needs to learn the skills to handle these encounters. Another reason to have a whole team meeting is that some members of the team may not know that this is even happening at their healthcare institution. They may have no idea. So you want to bring this to light, not only to inform the team, but also as a means of protecting the person who's experienced the rejection from internalizing it. Because, again, the rejections can feel like an assault. And this feeling of, this demeaning feeling is more likely to happen if the person feels alone in the experience, or feels that they won't be supported, or that people will accuse them of being overly sensitive. Because, again, for some providers, this is a macroaggression that's coming on the heels of several microaggressions. So supervisors in the institution have to provide support with an eye towards crafting an appropriate response, which can include the tracking and collection of data, okay, to get a baseline information on how often these encounters occur, the institution's response, the ultimate resolution, the effect on physicians and others, how personnel feel supported, and how they feel about the institution's response. You want a real, meaningful, systematic understanding. Make a prevalence map. What departments is this happening in most frequently? And again, all of this is to create best practices. The more information you have, the better your response will be. And finally, in order to be most effective, institutional responses have to be accompanied by institutional culture change. As we've seen with the most recent tide of sexual harassment allegations in the Me Too movement, many of the people bringing these claims worked for employers that had anti-discrimination policies and anti-sexual harassment policies. But there wasn't a norm of coming forward. People didn't feel safe reporting. Perhaps they didn't feel that their claims would be taken seriously, or they felt that their claims would somehow come back to bite them by negatively affecting their career trajectory in some way. And the same can be said for how some healthcare providers might feel about coming forward and reporting mistreatment by patients. So even if you have the best policies and protocols in place, a culture of non-reporting will undermine any meaningful change. And we know that norms play an important part in shifting behavior, because conduct is governed less by formal rules than by normative practices that have accumulated power over time. So supervisors have to be sensitive to this, and institutions have to be sensitive to this, and create a norm of reporting and a culture of supporting. So there's more that can be said on this topic. I'm going to stop here. I think I've sort of laid out general guidelines. And I think now we're going to open it up to a panel discussion and to questions.
Okay, good afternoon. Thanks to all for coming. Hopefully some of you were here this morning and decided to come back this afternoon to engage in more of hopefully an interactive discussion. So I'm Kenrick Duru, a general internist and health services researcher. So our plan was, which I think we'll still do, is to maybe give people a chance to speak first if they wanted to add anything briefly, and then I'll leave with one or two questions to stimulate discussion, and we can open it up to questions from the audience. So I know Dr. Paul-Emile spoke, but Dr. Fernandez, Dr. Brooke, any thoughts before we start?
No.
I was going to add a little in a couple of minutes. I think what you heard is an extraordinarily important presentation that needs action immediately. But I think there's a much more important one in this field. And I'm going to tell two case stories. One is about Belfast, Northern Ireland, and one is about Rwanda. In Belfast, Northern Ireland, if any of you have been there, I thought there was peace before I went there. There is a population of Irish Catholics and Irish Protestants, and through the center of the city there's a 10-mile wall that's 15 stories high with barbed wire on it that separates the Protestants from the Catholics. And in the evening, this wall crosses the whole city. The gates are closed so that you can't go from one side of the city to the next. So that young men, Protestants or Catholics, when they get drunk, as they do apparently in Ireland, have to drive entirely around the city to beat up somebody of a different religious background. And that was based upon the best that this society could do in terms of what mothers, agreed by the mothers of these children or boys that are Catholic and Protestant. Then Rwanda. Rwanda, as you know, was Bill Clinton's, as he puts it, biggest mistake, letting genocide go on for a long time. You go to Rwanda now, you see a capital city that's spotless. The two groups that killed each other really ruthlessly now live and work together, and they have a new way of living as human beings. So the question I would ask to you is that the future of the human race is dependent upon becoming Rwanda and not Northern Ireland. That's going to require a huge active role by you, the medical profession. By medical, I mean everything from a health person that provides food in the cafeteria to the doctor to the CEO. The real issue is I would love in 5 years for you all to present evidence to me that the number of these incidents that were described have been reduced to zero. How would you do it? What role would you play to make that happen? In the meantime, we have to do things to treat people that have been affected by this. But the first question is, how would you go about reducing this by using your medical, nursing background, physical therapy background to reduce this to zero so that we don't have this presentation anymore? What would you do to make that happen? Is it unrealistic? And then in my lifetime, when I grew up, the purpose of medicine was to do two things, was to treat acute injury and to prevent a few people from dying before the age of 65. That was our goal. We did virtually nothing else. Probably the biggest effect of medicine on the health of people in the last 50 years is to decrease smoking among the population. The medical profession played by medical, I mean nursing, medical, everyone played a major role. So I have ideas of how to do that, but I don't want to go on more than the 3 minutes I said I would. But I really would like to have you come back, and if I'm still around in 10 years, have you make a presentation to me that says, we've eliminated this problem. There aren't any of these events anymore at UCSF or San Francisco General, because these are the actions we took as somebody in the health field.
So interesting, Dr. Brooks, to have you make that statement, because as I know you're aware, the number of hate crimes has been going up in the United States. So there is national tracking of hate crimes, and those have been increasing in the last 2 years, particularly anti-Semitism, for example, which had been at a relatively low rate, has increased dramatically. So from your mouth to God's ears, let's hope that this goes in a different direction. Shall we,
Sure.
how would you like?
Sure, yeah. So maybe I'll start with a question and get the thoughts from the three of you on this. So, I mean, to me, it seems pretty clear that, we, those of us who are in leadership positions, as an attending physician, I would consider myself to be one, really need to be responsible for the climate in the workplace, because we have some authority there. I think there's, like we mentioned earlier, there's house staff, there's residents, there's students, there's also physical therapists, respiratory therapists, nurses, there's food service people, everybody, right? And, if a patient is using the N-word every day, all day in the room, I mean, that leads to a climate that is, it's a bigotry-infested workplace, right? But there was also talk about, I think, we tend to just brush things over, and there was talk about, if people have dementia, or there was a case study, the first one, if someone is intoxicated, you say, well, that's not really them, and it's not really a cognizant expressed thought. But, I mean, the knife cuts regardless, to me, if someone, whether or not someone has dementia, if they're using this language, it still has the same similar effect. So just thoughts on that it was kind of your assessing decision-making capacity arm. It says negotiation and persuasion, but really either whether you're impaired or not, in terms of our responsibility, what we should do to create a bigotry-free workplace for all of us, kind of steps that we could take, or steps that other people have taken in other institutions.
So this is a great question, and I want to separate out into two parts. One is, what is our responsibility, particularly for those of us who are attending physicians? And the other one is around how to consider the actions, including verbal actions of patients who are impaired or have diminished capacity in some way. I think the one that is the most straightforward and important is what we can do as attending physicians, and I think there's so much there that we can do, and this comes up all the time. I work at, as you said, at San Francisco General. We have plenty of patients who, when I go into the room as the attending, are perfectly polite, and then the nurses tell me that they've been absolutely horrible. And I think that's where we have a clear responsibility to set limits to the patient, with the patient. And that's where there are institutions, and including my own, who at different points have developed special teams that can institute behavioral guidelines with the patients for whatever reason is motivating their bad behavior or difficult behavior, that they can come in and create a behavioral guideline that takes some of the pressure off of the individual clinicians or staff involved. And I think that's an excellent policy. With respect to the issue of doesn't it still hurt even though when the patient has diminished capacity, absolutely. At the same time, and maybe I'm not the right person to speak to this, I think it's different, and it doesn't. And I feel sometimes for those patients, and I've certainly had the experience, and I'm sure you have and others, where the family members are mortified, saying, he didn't used to be like this, and now he's demented, and all of these strange things are coming out. And I feel there, my responsibility is clear in terms of maintaining the therapeutic alliance, trying to realize and caring for the patient.
I'm going to say a couple of other things. I having gone through more hours of sensitivity training in supervisory roles to trying to identify all this stuff, and then knowing all about all the laws that have been put together, one has a responsibility to understand what's going on. We don't have the slightest knowledge of what's happening in our institutions. The very least we ought to have is a zero tolerance policy for reporting anything. zero tolerance policy. Everyone ought to feel the obligation to report and then to begin to do something about it. I don't know whether this is occurring if we have 500 beds in this hospital or slightly less. I don't know if it's occurring once a day in the hospital, 10 times a day, 50 times a day. I don't know if most of them are occurring to nurses. We have a lot of feelings. We have no data, zero data. We don't know whether the people that are the most uncomfortable are the people that clean the rooms or give PT, or we don't know. We don't know if it's in pediatrics, it's in medicine, or where it is. We need to know. And I would go so far, if I ran this place, of firing people that didn't report. And I'll tell one other story. Paul-Emile, when he ran COA, he was the Secretary of Treasury, decided that the most important thing that he could look at each morning when he came in was not the finances of the company, but how many people were injured in making aluminum. Aluminum is very difficult to make. He looked at the number of people that were injured, and he said, we have a zero tolerance policy. We're going to reduce our injury rate to zero when we come in, no injuries. He did it, very close to that. And one person in an open meeting came to him, a worker, came to him from Mexico and said, they're lying, they're not reporting the data. Next day he was on a plane to that plant, figured out who was telling the truth, and the people that were running the plant were gone. There is no excuse in this day and age for not trying to figure out something legal, which our lawyer friends can tell, that would deal with the second of you need to report. That's what the law says if you're in a supervisory capacity, as far as I know, and I don't think hospitals are exempt from that law.
And I'd like to add, I think that's all right. I want to sort of reiterate what I've said, and also add that there really does need to be a systematic response that includes, tracking and prevalence to find out where it's happening. There has to be a mechanism for reporting, a clear mechanism, and there has to be support for people who are coming forward, but also there has to be protection for people who are reporting, so that they don't feel that their supervisors are going to say, you're always the one saying that you're so put upon, you can't always be the victim, and yet these things happen to people, and sometimes they happen repeatedly to the same person. So yes, there should be consequences for not reporting, or at least I think there should be consequences for not tracking and documenting. But before we start to focus on not reporting, we have to make sure that that people feel safe. There are systems in place for people to report and not fear.
Can I ask a question? That's true of every industry. And why are we so concerned that we're going to be worse? Do we trust the CEOs, the people that run nursing and medicine and surgery less than we trust the people that run economics, social science, and all those other things? And maybe nobody is trustworthy. But I at least hope that the people that are hired to run these places are at least as trustworthy as the people that run our financial institutions or whatever, and they have those requirements.
Okay. They do, but the problem is, just as you noticed with Me Too, is that, again, they all have those policies, but people get fired for reporting, people get frozen out for reporting, people get demoted for reporting. And again, you're right, the goal should be to have everyone feel confident that their complaints and their concerns and their treatment will be taken seriously, but we haven't arrived there yet, sadly.
All right, so I'd say I don't know that we have a microphone out there, but we have 15 minutes, so maybe we can open it up to questions for the panelists.
That's about when we give the talk. That's about the number of people that and how you would deal with it. People want to share experience.
A lot of my experience with education parents perhaps and so a lot of my and so all I can do is try to go back more after suffering so and I don't talk about the things that I need to, but I kind of think that it doesn't always work, but if you go time and years, I am able to with my skills about I have that was not doing this today. It's hard to well, I'm in Carolina, and several years ago, I was a patient of ours, and they doesn't someone got surgery, and the patient was so driven that he had to go to the rest of the treatment. And I came out and I told him our was so driven that gone. He only went back home to go back to Mexico, and then I have to go to church because he was not coming down. And she just I remember I was like, well, they did that. This is that I was different. So this was several years ago. Sophie at that time said, I didn't know what to do. I just already not as a good job. The physicians say some physicians are good at taking down some of the time. I was hoping that the movie starts to because he's not a patient with a medic. But yet the with more expert staff, but the practice and not to get it done. So how do I do it? How do I report that? Who do I report?
So thank you for sharing that story, and I'm so sorry that happened. But I think it beautifully illustrates the need to have a mechanism in the same way that patients may go to patient relations or there's an ombudsperson or something. There needs to be a mechanism, particularly, I would say, for non-physician staff who are usually less empowered and have less autonomy to be able to have a mechanism for reporting and for making sure that supervisors back up the staff as appropriate. So again, thank you for sharing that.
It is very interesting that patients are so empowered for the staff, and yet us, the staff, is not supported because we don't know how it's going to be done, what is going to be done, and we bring it to a physician, and as far as I know, I could do something wrong, but I'm wrong. But for example, just days ago, I had a patient but the patient told them, say, we didn't have certain records, and patient related told me, because what are you going to do about it? Well, what is it that you want me to do? I thought patient relationship there because of the situation and not holding the ball to the other side.
I think, again, this underscores the need not only to have open conversations about these things, but to have data collection, data tracking, and institutional policies. And it's not, and as Kimani said, it's not enough to have an institutional policy like there is one against sexual harassment, at least, for decades. There has to be a cultural change, and I think Dr. Brooks has spoken to that very well.
I would say exactly the same thing. What you're pointing out is a failure of the culture of the institution. And I'm sorry of what happened to you. And what you're also pointing out is you can remember vividly this event that happened years ago. And to this day, I'm sure it's affected your life. And nobody cared. Or, period, end of statement. It's a failure, a cultural failure. Now, if we have a lot of those, maybe I wish it was only one, could you start a movement? I mean, there was the civil rights thing there was a civil rights movement. There was a women's movement. Should there be a movement in health institutions to say, how do we develop a culture where we have all of these problems? We want to give our patients the best care. We want to take advantage of the fact that that we have all this expertise. We know that there are different reasons that affect how patients act out because we're tuned in psychologically, mentally, and all of this stuff. But we're people, and we need a culture in this institution. And that conversation has to occur. And maybe the value of this is to take the ethics group and all of you and march into the office of the CEO, sit down for a few days like they did in the 60s, and begin a march to solve the culture. That they can fire me now because I'm now an emeritus professor. They couldn't fire me as a month ago, but they can fire me now. But the bottom line is, I think that, and I don't mean you don't have to do it confrontationally. You could do it with Gandhi's approaches and Martin Luther King's approaches and begin to try to say, how do we change the culture so you don't have these vivid memories 10 years later?
If it's okay with you, one of the things that we've done is that we've had several people speak because I want to get lots of voices into the conversation. Do you have a brief comment?
Yeah, so there's the opposite extreme, and it does go the other way. When we've had difficult patients that have been unkind, mildly, we've talked to them, and ultimately, and typically patients don't just do it in one area. And those patients are trapped and they are excluded from our system. So there is an avenue. The thing that I find that I'm unaware of at UCLA is the part of actually providing emotional support to staff members that have gone through bad experiences so that they can feel heard, supported, have some healing. I know we have a counseling center here, but I don't know that actually deals with this particular experience.
Would it be okay to get?
Oh, go ahead. Yeah.
To get a few comments?
Sure. Sounds good.
There were other comments?
I guess, when I hear, and I'm a therapist and I work in a psychiatric hospital, so part of it is like trying not to take things personal. That's how I function, and I know it's hard because everyone is raised in a family, or their own training, their own beliefs. So when I have someone discriminate against me, I don't internalize it. I guess to me kind of take it personal. So if a patient is delusional or whatever, they're really angry, they're in pain, and they say something horrific to me, I don't internalize it because it's someone else. So it also is a lot about who we are as people. We're not going to change our patients, but we have the ability to, for individuals to get therapeutic support or whatever, if it is disruptive to them.
I would just like to say that we have new regulations about this violence, and all of this is within that, and that has developed because of the inaction that has happened between. And whether you want to just take it as what it is on the surface or what the regulations are, or expand it to what you're talking about, I think we all need to look at it in terms of what would make it even better than a regulation. I personally was assaulted and also verbally assaulted by a patient who called me a jab. I happen to be half Japanese and half Italian, and she was outrageous, and it wasn't fun. And while I may know some of these techniques to be utilized in the environment, right? It's as though, what did you provoke in this patient, as opposed to just the fact that my presence created that reaction. I also think that while we have patient relations that may help with some of these things, there are, in a number of examples that I have heard from other nurses, where they can be fired by a patient's family and the nursing manager or director on the unit supports them.
So,
And I have big questions about whether or not the patient is always right in that circumstance. And there has been, I think, a swing on some of the PI care that's been developed across the institution that maybe we've swung a little too far in that respect, and not enough of a place where an ombudsman really is there for the staff, on behalf of the staff, that maybe can enrich the culture of management in relationship with staff itself. Because the workplace violence came out of staff pain and suffering.
so we've been doing focus groups as part of a grant that we have from the Greenwall Foundation to look at this issue at UCSF. And what's clear in at least some of the focus groups is with trainees, particularly, is that what hurts the most is the lack of support from supervisors and from other colleagues rather than the patient's remarks. And and there's an article that one of our colleagues published who was then a second-year resident in family medicine. She wears a hijab. A patient made a horrendous anti-Muslim comment to her. The whole team was rounding. She's in family medicine. The team sort of like stopped and just continued rounding. These are family medicine doctors, right? Like the best, most touchy-feely doctors in the hospital, right? And it was because they didn't know how to respond. But her pain, in addition to coming from the remark of the patient, also came from the lack of support of her colleagues, that no one talked to her about it, no one said anything to the patient, and so on. And some of what you all are getting at in your comments speaks to that. And that, I think, is something that with training can be overcome.
So I'll say it's 1 o'clock.
Can I just agree
Last thing,
to
sure.
that strongly, that the bottom line is, but it can't all be done with a small grant at UCSF. I think there is an opportunity, and there's a lot of hope to do it here as well. And you all, you came here, you came to listen to this. The question is, how do you mobilize into making something happen? I'm going to end with my story on when I came to LA for the first time 50 years ago and tried to have when my parents and I came, I should say, 50 or 60 years ago to LA, we tried to stay in a motel along Wilshire Boulevard, and they wouldn't accept anyone who was black or Jewish. So the hope is that there is progress. Hopefully it won't take another 60 years, but I hope that an action plan, the UCSF people have a strong action plan. I would hope that there would be a strong action plan to try to work on this here as well. If there isn't already, there may very well.
All right, so I think we can close there given the time, but I'd like to ask you to give our panelists a round of applause.